today's Airway Management. I have this based off of that you know nothing, that you know absolutely zero about airway management. So if you have a background, it may be a little boring, but it goes from very basic all the way up through surgical airways. So also 2 hours or an hour and a half to cover airway is not a lot of time. So this is somebody's whole specialty in anesthesia or in ER. We spend months on learning this. So we'll reinforce a lot of this next week in the lab. This will kind of lay the foundation for you to kind of understand what's going on. So let's get started. So airway management. Why do we even study airway management? It's really a skill all professionals should have. You may be somewhere, no matter what you go into, you work with a hospitalist, you are in surgery, and somebody desats in the PACU, or you're rounding, they're going to lift you. And so you're going to be expected to be able to manage the airway. And it may be at a car wreck or outside the hospital, but it's something everybody expects you to know. So why do we worry about the airway? Why do we take over, protect, or innovate somebody? So here's a whole list of reasons, but the main thing is that we're worried about oxygenation and ventilation, two issues. These are reasons why people have problems with oxygenation and ventilation. So you can see, you can have a primary issue with your airway, you can have a foreign body, you can have a infection, you can have a hematoma, bleeding, whatever it may be. It can be traumatic, you can be shot, stabbed. It can be a breathing issue, not primarily the airway, but lungs, heart, congestive heart failure, COPD, asthma. Also people on drugs, that last one, feral. They need immediate aggressive sedation to protect their airway. They are out of control. Sometimes protection for yourself, protection for the staff, but protection for the patient. Or expected course. I've had to intubate people that have to go to MRI because they're going to be over there for hours and you have to protect the airway. Also, sometimes people will have bad strokes. They'll bleed in the brain. They'll lose their ability to breathe on their own. You can have worsening Guillain-Barré, all kinds of things, or they're in status. They don't stop seizing. Or you don't know what's wrong with the person. They're just not breathing.
Yesterday's video, the lady ran into traffic. She should have been sedated and intubated and put on ventilator. But bottom line, in America, that's what would have happened.
So, to know about the airway, we need to kind of know some basic anatomy. So very basically, you can see there the upper and lower airway. Really, we'll keep it very simple. You need to know where the tongue is, that leads to the epiglottis, that leads to the trachea. And that's about it. It's not real complex. So having that burned into your memory is very important. There's a little bit more detail. You'll read a lot or hear a lot. People will say the nasopharynx, the larynx, the oropharynx. Basically, that is the divisions between those areas. So nasopharynx is below the palate, oropharynx is basically the back of your throat, and the laryngopharynx is below kind of the epiglottis. So this is the area. If you can kind of remember that cross-section and remember the relationship of tongue to epiglottis to trachea, you'll kind of know where you are when you get into actually intubating somebody. But most important, we'll call where the money is. This is what you're looking for. So when you go to intubate somebody, whether you're doing a video laryngoscopy or what we call direct laryngoscopy, you're trying to find this. So what you can see there is the epiglottis at the top. You see the vocal cords, and then you see a variation. This picture, this cartoon, is probably not really accurate because you can kind of see how the arytenoid cartilage and the cornicate cartilage kind of come together. The V doesn't really happen like that in most people. It's usually separated. So here's a video snapshot. So you can see in that top picture, you can see how those don't come together like the cartoon. This is a great picture. It's not always that great, not always that well. At the bottom you can see the ET tube passing through the cords. This is probably a little bit more realistic, a little darker. So that picture correlates with the diagram. So what you see at the top is the epiglottis. That's your friend. You're always looking for Mr. Epiglottis. Right underneath it, you can kind of see the arytenoid cartilages. And then that very back part is actually the tracheal ring. That kind of bright, this bright little thing right see that. It's not always that bright. Nowadays, with the scopes we use, the video laryngoscopy, they're super bright. They're fiber optic lights. So, as in the old days when we used little bulbs, your vision is much better now. So, remember this shot. So, this is as if you're looking with someone laying down. So that epiglottis is up high, and basically how that guy's laying right here. That view, that correlates with what you see here. So, chin up here, back of head down here. This is what you're always kind of looking for. And if you find it, you're very happy. When you don't find it, is when you panic. All right, so that's anatomy, very basic. So how do we control airways? So to start with, there's certain airway maneuvers. Basically, when someone is having difficulty, you're going to do certain very basic movements. So it's positioning them to optimize how much oxygen and air they can get in. So people brush past this, but if you don't get positioning right, you'll just fail from there on, and it'll cause you to have a lot more problems trying to get someone innovative. It will decrease the time you have to work with, and it'll make you very anxious. So there are basically three things we're going to talk about. Most people can tolerate sitting up, unless you're talking about a trauma patient that comes on a backboard, you're worried about their spine. Otherwise, all medical people will most likely be able to sit up. So you can kind of see the guy in this picture. There's a reason we want people to sit up. It opens the airway. It's very simple. The last thing you want to do before intubating like this guy is lay him back. You can do everything. You can start to get ready, keep him sitting up, getting in an IV, put him on oxygen, get everything assembled, talk to him, and lay him back at the last possible second. You don't even have to lay him all the way back. So initially, people that are in extremis are going to want to sit up. They're going to want to sit up. They're usually sitting on the edge of the bed. They're usually leaning forward, and they can't breathe. So that's actually, they're trying to help themselves. So the supine position, laying back, is compromising the airway. Everything will fall back. That soft tissue, the tongue, and include the airway. Sounds simple. People screw it up all the time. The next movement is after you lay them back is what's called the head tilt chin lift. You can learn this in BLS. It's a very basic maneuver. Basically, you put your fingers under the chin, pull back while kind of pushing their forehead down. That kind of opens up the airway. It doesn't do a lot. It actually positions the airway. It doesn't do a lot to open it. You can kind of see on that little cartoon on the guy, it's really not that dramatic, even though they show it. It really doesn't do this much. So this is more aligning what we call the axes of the airway so you can see. So this is done right before intubation. What's more important, what actually helps out the airway a lot more, is a jaw thrust. So if someone is laying back or sitting up, just reaching behind the angles of their jaw and pushing forward. That's it. You can do that when you're sitting up. You can actually pull it. Or if they're laying back, you can just push up on their mandibles. Hold on. That's what's going to open the airway greatly. You do it in kids also. Little babies, you can just basically put a couple fingers under them, push them up. And it makes a huge difference. Whenever we're doing procedures and we consciously sedate somebody, sometimes you'll hear them start snoring. All you have to do is go over, little jaw thrust, they open up, their sac goes way up. It sounds simple, but I'm telling you, anesthesiologists, people screw this up all the time. Here's a demonstration. You can see these bilateral x-rays. So this is just putting someone into a head tilt chin lift. You can see the distance on their airway. Not that great. Here's neutral position, as if you didn't move. And then here is that, basically a thrust of the jaw. So you can see it almost doubles your airway. That's why that one maneuver, if you get in trouble, can really make a difference. So here's someone sitting up, jaw thrust, open up the airway. They may be doing it on their own because a lot of people will just lean forward. But a simple movement of that jaw forward will greatly increase their airway. The other thing considering in positioning is if you're worried about somebody's C-spine, if it's a trauma victim or something like that, the main way you control the C-spine in an airway is what's called inline mobilization. So you have two people. So you can kind of see somebody is doing nothing but holding the head. So this guy's got both hands on both sides of the head. Same thing here. This guy's both sides of the head. And you're just trying to keep it straight. You're also trying not to rock that head back. It's difficult, but you're going to want to. If it's a very serious concern for a C-spine, you'll probably go right to video laryngoscopy and try to minimize the movement. So you can see how many hands are here. You want a lot of help. One person doing nothing but controlling the C-spine. You can see this person here. Y'all know what they're doing?
Moving the trachea.
So they're doing what's called a Selleck maneuver, which is cricoid pressure. Old days, we used to think, well, that'll decrease aspiration. You smash down on the trachea, the cricoid, smash against the esophagus, and it'll keep people from aspirating. It doesn't matter. It doesn't hurt. It's uncomfortable. We don't really recommend it anymore. A lot of people still do it. But in fact, there's a study last week finally saying, again, don't do self-maneuver. It doesn't help. So this section is called Airway Agilents. Basically, things you can do to help people breathe, or what you're going to do before you intubate somebody. So the first thing is what's called an OPA, oral pharyngeal airway, or most people just say oral airway. It's that little piece of plastic. So basically, this little thing, that's the only thing they have, basically goes into your mouth and kind of conforms to the shape of your tongue. It has this kind of big flange out top and helps to kind of open and push the tongue out. The way you insert it is kind of counterintuitive. You would think, yeah, I can just push it down. Most of the time, you actually do it 180 degrees. So that curve is actually against the tongue, opposite, and as you get down, push it. What I do is if the person doesn't have a gag reflex, because they shouldn't get one if they do, I just put my finger down, and they're not going to bite me, and just push their tongue down and put it in. So what that'll do is kind of open the airway, kind of stent the airway open. A lot of people, if they're unconscious, you can go ahead and put this in right away. It'll help in bagging, help deliver oxygen. It's a very basic maneuver, and one that a lot of people will come in from the paramedics with. You put something in the mouth, you put something up the nose. So this is an NP airway, nasopharyngeal airway, or people call it a nasal trumpet. So you can kind of see it's a long, basically plastic tube. It's nice if you would put some like KY or some jelly on it. Lidocaine doesn't really matter because if someone's getting this, they're not really going to care about the discomfort. So you can actually put them in both sides of the nose. This also helps in opening an airway. You can kind of see in the little cartoon, you can measure it basically from the side of the mouth, the side of the nose, to the angle of the mandible. But basically it's another way to kind of stent open the airway while you're getting ready to intubate somebody. Basically, before you intubate anybody or help their airway, you're probably going to bag them. So BVM or bag valve mass ventilation. So every hospital and almost every bed, like in an ER, has one of these sitting on it. They have an adult size. This is an adult size. There's pediatric. There's neonate. Everybody calls them an AMBU bag. And that's just because that's the company that has made them forever. So what this is a bag that you hook up to oxygen. And that's always embarrassing when you don't hook it up to the oxygen. That happens. So you hook this up to your wall oxygen. What will happen is this reservoir will inflate and basically hold all the oxygen, and you hook it up to a face mask. So this is kind of your standard face mask. This is one of the most important things I can teach you today, is how to bag somebody. It all starts with placing the face mask. If you can't place this correctly, you're never going to bag someone right. I see people misplace these all the time. The easiest thing to do is, before you connect this, is put the face mask on the person's face. So what you want to do, you can kind of see the shape of it. Obviously there's a kind of anatomical shape. You want to go over the bridge of the nose and under this ridge. You don't really want it under it. You want it on the roof pull. So you can kind of see how there's still space here and there. And it doesn't hit my eyes. The other thing, you don't want to smash someone's eyes. You can sit there and scrape and abrade their corneas. So you want to be real careful about placement. This comes in different sizes. It comes in larger, smaller, little bitty, every different size. It's usually based on weight. Is how, like, the bag is usually kind of labeled. But it's easy to see on all the bags, the size of the mask. So as soon as you have it placed, then you can attach it to the end of the bag. So you can kind of see on the diagram there parts of it. It's pretty basic. The bag, the O2 reservoir, hooking it up to the oxygen, and there's kind of a pressure gauge right here. You can't really overinflate it. So, tricks of placing the mask. The whole key in bagging someone is this fit and seal of the mask. So we want to proper size it, like we said, over the bridge and over the ridge. Kids, you also, same kind of deal. You don't want it over their eyes, you don't want it under their chin, you want it kind of in that same area where it's covering the nose and the mouth. But don't forget the bottom of it, not over the chin, but in the ridge, right there. All right, so there are two methods really of how to bag somebody. We'll kind of talk about that, the ear to sternal notch, in a second. So the two methods are what's called a one-handed technique or a two-handed technique. So the one hand is called CE technique. If for some reason, I don't know why, you'd be by yourself, and you have to do the one-handed technique, you can, but it's really preferred if you can have two people. One person's doing nothing but holding the mask, the other person's doing nothing but squeezing the back. So this is incredibly important. So you can position the patient like that guy there, and what we look for is you can see the ear to the sternal notch. You want that basically in alignment. You can see how they did that. Look at under his head. There's a ton of blankets, sheets, whatever, that you've elevated the head. So you've made that a straight line. That will help align those axes. You can see in that other picture, don't really have to go over it. Basically, you're aligning that so you can see down the airway. So here's the one-handed technique. You can, why it's called CE, you can kind of see if you're putting your hand on the mask, on someone's face, it basically makes a C. So you're putting it over it and you're holding it with those two fingers, your thumb and your index finger. And then your other three fingers reach under the mandible. So you can kind of see they're putting it on there, and then they're reaching up, grabbing the mandible, and pulling it all together. So it's not that you're smashing this onto someone's face, but you're pulling the mandible and the face into it. It gets tiring because you're using these three fingers to kind of pull, gets fatigued, and a lot of times what happens is when you put that on somebody's face, you always tend to kind of rock and all the air comes out the other side. It's okay if you have to, but like I said, it's not the preferred technique. You really want to use a two-handed technique. So, two people, and what's considered the best is what's called a two thumbs down. So two thumbs down means two thumbs down. So, as you see in the picture, basically this is on someone's face, and they are putting their thumbs down, and then they're grabbing both sides of the mandible and pulling it into the mask. So you're not just putting all your weight onto the person, you're literally grabbing and pushing these two things together. It'll create a great seal. Can make a dramatic difference in being able to bag somebody. Because you want to be able to bag somebody. If you can bag somebody, you can oxygenate them and ventilate them, you can calm them down. You can be, okay, we have time, we can get set up and plan what we want to do. It's really bad when you can't bag somebody. If you can't bag somebody and you've tried all these things, then you've had this crash airway and things really get out of control really quickly. If you can't bag somebody technically because you don't have these skills, it makes your life very hard. Being able to have these basic skills will make your life much easier. So it sounds real simple, but when these airway things happen, things get out of control, and you start to not remember the simple basic steps. So, two thumbs down, one person does nothing but squeezing the bag, the other person is doing nothing but pushing on the mask, squeezing the mandible, pulling it together. here's basically the 3 techniques. So the first one is the one-handed, so you can kind of see that top picture. It almost looks painful. It looks like someone's really reaching hard to kind of grab that mandible, pull it together, and you can kind of see how on that side, how there could be a leak. You can see right here. You're putting all your pressure here, the air usually just comes out over here. Same thing again. And if you have small hands, it's really hard. It's hard to capture the entire mask and 3 fingers under the mandible, depending on the size of the patient. So, you're going to have help. There will be people there. 2-handed. This is the 2 thumbs down right here. This is the side view. And actually, that's not thumbs. Those are index fingers.
Yeah.
There's the 2 thumbs down. This is basically another way where you're just having your hands kind of the thumbs at the top. It's just where you're positioned. But same thing, reaching under the mandible. Again, pushing not downward on the mask, but pulling the mandible into it. And kind of creating the seal by pulling. Now, everybody has facial hair these days. Men, I'm talking. So beards cause a huge problem. It will just not create a good seal. So one way around this is you can get a tegaderm. Tegaderms are everywhere in the ER. If you don't have a tegaderm, you're going to have the crash cart. Just grab a patient pad. So patient pads are always on the crash cart. Just tear a patient pad off, cut a hole in it, and put it over the beard. So that's what's sitting on this guy's beard, the tegaderm. So this tegaderm is just like saran wrap with glue on it. So you just smash it on there, that's all sticky, poke a hole in it, and you're sealed. So you have a good seal. But it's a huge problem because there's so many, it seems people that have problems with their airways have beards. They have beards and no teeth. The other person that's hard is the person with no teeth. You would think it would be easier to bag them, but there's no structure. So when you start bagging someone without teeth, their lips just sit there and flutter. And it'll leak out the sides, same kind of thing. Here, the trick is you put the bottom of the mask, that's usually in that groove that we talked about, you stick it in their lower lip. So since they don't have teeth, it actually will seal. It'll probably ride a little higher than you'd like to, because it's a little higher than the bridge of the nose, but it'll create a good seal. Probably have to pull pretty hard on their mandible and get a good seal. Definitely it's going to take 2 people to do that, but that's the way you can actually bag it. I've bagged plenty of people without teeth. You do it the regular way, and it's just flapping. Just every time you bag. So just kind of shove it in the bottom of the lip. So the way we bag people, the ventilation depends on a couple things. So the volume, how much volume somebody gets. So this bag, you can kind of see, you know, this is a lot of volume. This is almost a liter. Well, most of us aren't breathing a liter at a time. In a code situation or resuscitation, you need about half that. So really, you don't have to, and you'll see it all the time, you'll see respiratory techs, you're sitting there bagging, people are just wailing along, you know, it just kind of panic. So if you can just kind of, that's why cadence, you just kind of smooth, constant, looking for a good seal and looking for a chest rise. The rate, again, people get very excited. No one is bagging at 10 to 12 breaths a minute, I can guarantee you. But you have to be aware, because all you're doing sometimes is just blowing up their stomach. So then when you go to intubate them, all of a sudden they burp or they throw up. So you just have to be really aware of these things. Again, things get really exciting, things get really panicked, and people start remembering the basics. And again, it makes your life a lot harder. So consciously think about the volume you're giving, the rate you're giving, and how fast you're giving. The other thing that helps in bagging is PEEP. So PEEP is positive in expiratory pressure. So PEEP is basically, y'all seen commercials for CPAPs? That's PEEP. That's what CPAPs do. They basically continuously give pressure even when you exhale. What that's thought to do is to recruit and stent our lungs. So it keeps them open instead of after every breath collapsing. It takes time when you exhale to get them back open. So it kind of keeps them open and stented. Well, this little $5 device is a PEEP valve. This is all it is. So it's just this little piece of plastic. So you can actually dial. Actually, take it apart. There's little numbers here that you can turn this down to. So if you turn it all the way, that's 20 millimeters of mercury of P, rotate it to 15. That's how much pressure you're going to give. But every time, I don't know if it goes with this, but there's a place for this. Sometimes they'll go on the back, on the end here. But every bag has a PEEP valve. So you put the PEEP valve on there. You should always use a PEEP valve. There's no reason not to use one. But what it does, it stints the lung open. It is easier to oxygenate and ventilate. You know, sometimes people have restricted lung disease. For some reason they're full of fluid, they're full of infection, and you may have to really crank this up to like 20 of PEEP to keep them open. So I can talk about PEEP and explain to you, but sometimes pictures, videos do a lot better. So hopefully this video works. Is there volume?
Yes.
We're just going to quickly demonstrate the difference between bagging a patient without PEEP and then bagging a patient with a PEEP valve. And you'll really see how much alveolar recruitment you can get with just 10 of PEEP and what that really looks like. When we're just ventilating the patient without a PEEP valve, we can see the lungs come up and they come right back down. There's a little bit of residual inflation, but not much. But now when I put 10 of PEEP on and bag the patient, there's a lot of stenting. And just 3 breaths gets these lungs up to a huge capacity. It's really important to use PEEP anytime you're bagging a patient. If you have a PEEP valve, you should be using a PEEP valve. And as soon as we DC, we lose all that recruitment right away. So when you're switching ventilators, when you're moving a patient from CPAP to another modality, you lose recruitment really quickly. So keep that in mind. A little PEEP makes a big difference.
So it makes a huge difference. That's why what you said, switching, you'll see it all the time too, is you'll sit there, you got someone intubate, you're like, great, they're bagging, okay, let's put them on the ventilator. They take them off, and they sit there. You're like, put them on the vent. You need to have the circuit right there, put them on. Because you can see what happens. You lose that pee, it's just, and then you have a diseased person because they have to be intubated, and they probably have a problem with stenting, ventilation, or oxygenation, and now you're, again, kind of behind the 8 ball. So, simple things to make your life easier. Last thing is BiPAP and CPAP. So, you know, nowadays, so many people are on CPAP for obstructive sleep apnea. We use it in a way to help not intubate people. So it's non-invasive. We're not putting anything down your throat. We're just putting you on this big mask. So you can see that guy. So that's the big face mask. Basically, you hook it up to, you can't really see the machine. It's kind of right behind them. But they're little machines. You have little settings you put in there. The 2 biggest things it helps with are COPD exacerbations and cardiogenic pulmonary edema. So CHF exacerbations and COPD exacerbations. So in COPD exacerbations, the main thing is these people retain carbon dioxide. So they become hypercapnic, they get confused, they get angry, they get a little acidotic, and if it continues, they'll eventually arrest. So you'll get a gas, and they may have, you know, a lot of people say they're a member of the 50-50 club. Their PaO2 is 50 and their PaCO2 is 50. Most of the time, their CO2 is even higher. They'll be 80, 90. They get CO2 narcosis, so they're kind of confused. It makes it hard to use BiPAP and confuse people because they'll start pulling at it. They don't want it on. They kind of fight with you. So there's a fine line to walk to try to give it time to work or mild sedation. So a lot of people won't give any sedation. I'll give low doses of Ativan and just very, very tiny doses just to kind of chill them out. Some people also do small doses of ketamine, just kind of chill them out so you can keep them intubated. But BiPAP and CPAP have really changed airway management over the last probably 10 years. So now most ambulances carry CPAP. They can put them on them right away, and you can really save a lot of people from ever having to be intubated. Contraindications, they don't have a heartbeat, cardiac arrest, it's not going to work. If they have severe encephalopathy, they're already pretty gone. Of course, if they have GI bleed and they're vomiting, They have some type of facial abnormality where the mask won't seal, they won't cooperate, or they're high risk for aspiration. They're going to throw up in the mask and then aspirate. All right. Any questions? I know we're going kind of fast. Stop me at any point. So, we've talked about positioning, some of the basic maneuvers. Now we're going to talk about actually how to control the airway. So the three things we're going to talk about are LMAs, which are laryngeal mask airways, direct laryngoscopy or oral trach intubation, that's what everyone kind of thinks of, or video laryngoscopy. So direct laryngoscopy means I'm directly looking without a camera. I'm just looking in the airway, the old school way. And then video is using all the fancy devices. And then surgical airway, Craig will kind of talk at the very end. So somebody needs to be intubated for whatever reason. So your goal is to oxygenate them and ventilate them. You want to deliver oxygen, and you want to basically move oxygen and carbon dioxide in what's called a protected airway. Protected airway means you can oxygenate, ventilate, and you can prevent them from aspirating. That's the other part of protecting the airway. So a protected airway usually is only an ET tube with a balloon. So basically blocked aspiration from reaching the lungs. So that's what we mean by protected airway. First thing we're going to talk about are LMAs, or laryngeal mask airways. There are probably 20 different products. There's so many models, shapes, sizes. So what they are is this. There's pictures over there on the side. Those are several different models. This is Ambu, another brand, their product. So laryngeal mask airway is this airway. So it doesn't go in the trachea, as you can see in that picture, it kind of sits in the back of the airway. So you can kind of see right here. It looks like an ET tube from here, but it's sitting in the back of your throat, basically. It's blocking the esophagus and then delivers through this little opening oxygen into the trachea. Again, blocking the esophagus, there's a port right here, oxygen goes in. This model right here is probably what we'll have to use in the lab next week. It's called an iGel. That's what the ambulances are now carrying. It's different because this cup here is just, it's not inflatable. It's basically just jelly, kind of. And it molds to the airway. Very nice. They're kind of the newest model. So this is basically what the LMA is. So this is kind of a balloon. You can inflate and deflate. And this is what you hook up to your oxygen. And basically you just kind of bag right through it. So all the air comes right through this area. This has a suction port. That's what that is. You can hook suction up to here, and you can send down a catheter and suck out the lungs. So these are sometimes used a lot in like outpatient surgery. Like if you're going to have your gallbladder out, hernia repair or something like that, you'll probably get an elevator. Of course, you can't put this in someone that's gagging, because they're just going to throw up on you. If they have trauma of the airway, they've been shot, they have burns, it won't work. Or if you're suspected they have a foreign body. If they have a foreign body, you're just going to shove that foreign body down farther. So you got to make sure they don't have that. A lot of people used to use this first, but again, this does not protect the airway. So it is not considered a protected airway if you just have an LMA. These can also move and dislodge. If you're transporting people, if they're flying them or whatever, you don't always like to have LMAs. Sometimes you don't have a choice, but you can kind of see by the pictures, they can easily dislodge. A lot of times they're used, if you try to intubate somebody, you can't intubate them, and you're kind of panicking. And you try to bag them, and you're having a hard time bagging them. What you can do is you go from I can't intubate and I can't oxygenate, I'm going to throw down an LMA. Now, I can't intubate, but I can oxygenate. So I can catch my breath, I can get the person oxygen, I'm not going to arrest, and we can think about what we need to do. A lot of the videos are foreign, because I guess with HIPAA, a lot of people don't want to video Americans. So Just enjoy the accents. How they made this video, you'll see. I have no idea. They use like blue fluoroscopy. It's kind of crazy. So this is basically how you put down an airway.
What we're about to demonstrate is the correct insertion technique for the intersurgical solus laryngeal mask airway. Firstly, it is important that you select the correct size for each patient, and the patient weight does appear on the airway tube. Next, prepare the laryngeal mask airway by fully deflating it to a very tight vacuum, contrary to some popular belief that there should be some air in the cuff. This is not so because a filled cuff can collide with the epiglottis. Next, prepare the solus for insertion by putting some gel or lubricant on the back of the cuff. Just on the tip of the backplate is all that is required. Then, in readiness for the correct insertion technique, insert your index finger into the slot formed behind the flattened cuff and the junction with the airway tube. Then prepare the patient by tilting the head back and bring the tip of the laryngeal mask airway laterally towards the patient, not downwards, but resting the tip behind the teeth and gums, because you're going to utilise first the hard and then the soft palate of the patient to perform a sweeping action that optimises the anatomy as an introducer tool. Inserting the laryngeal mask vertically or obliquely brings about difficulties, but by following the curve created by the palate, rather than bouncing off the back of the throat, is by far the simplest method of effective insertion. So we are ready now to start inserting the laryngeal mask airway. And there you see it, following the natural curvature, with the finger going as far as it can, and then using the other hand to stabilise the laryngeal mask as you remove the introducing finger. Then with a pre-prepared syringe, inflate the correct volume. You will notice that not only is the cuff inflating in the pharyngeal cavity, but the connector is also rising slightly, which is an indicator that the laryngeal mask has been fully inserted. The tip of the cuff is now sitting over the esophagus, which is acting as a form of partial stopper, either against reflux coming up or possible minor leakage of gases into the stomach. The epiglottis is resting over the top of the cuff, and the whole of that section is now completely filling the pharynx, which is a special feature of the laryngeal mask airway, because now the nitrous oxide or other gases are being directed solely through the trachea and into the lungs.
So it looks pretty easy to insert. They relatively are. Sometimes you can run into problems where you catch the tongue moves back, or you fold the epiglottis. But you can always assist yourself with the laryngoscope while putting it in. But it can really save you in a tight situation. There's a type of LMA that's called an I-LMA, or intubating LMA. So you cut back a person, you got in trouble, you're able to put the LMA down, but you can now oxygenate them. So you can kind of see the little opening over there, right here. So this is open, has this little flap there, and that's supposed to elevate the epiglottis. Basically, it comes with a special ET tube that you can basically put through the LMA, and it goes into the trachea. After that's in, there's a little extender you put on that tube, and you can just take the LMA out. So this converts a non-protected airway to a protected airway with an ET tube. These were a lot more popular before video laryngoscopy came on. We used to do these a lot 15 years ago, before video. Video has really changed everything. So this is an option. You may see somebody come in, transferred in with an LMA, and have to convert them over to a regular ET tube, and that's kind of how you do it. So the LMA, like I said, is a lot of time used as a last-ditch effort for someone that you can't oxygenate, but you can get that in, and at least oxygenate and buy you a lot of time. Any questions?
How did you say your wrist? Because it looked like they just put it straight.
So what I do, you can put your tongue, a lot of it's like gagging yourself, like you're going to throw up. That's what you're doing to that person. A lot of times I just stand by them, I grab their tongue, push down, you just take that thing, push down their tongue, and just rotate it. You just kind of follow the tongue, follow the palate, try to catch the palate. That's why you lube the back and go around.
Okay.
So.
Thank you. So you're standing in front of the patient, not
Right, I usually stand beside, yeah. Some people stand behind them and will use a laryngoscope and try to put it in. At that point, if you're doing this, you're probably trying whatever you can. All right, so direct laryngoscopy or whole trachea intubation, this is what everybody thinks of when you're intubating somebody. This is the fancy definition: direct visualization of the airway to place an intratracheal tube in the trachea to protect the airway and provide a conduit for oxygenation and ventilation. Basically, it's putting a piece of plastic through the course. That's all it is. This is an ET tube. Every ET tube you'll see on the package will have a size. So this is a 6.5. So that refers to the diameter of the tube. So this tube is 6.5 millimeters. That's the diameter of the tube. That's how it rolls. So 6.5, this would be for small adult, large teenager. Usually I try, the bigger the tube you can get in, the better. Because we all have to take physics. The law, I'm trying to remember. It's been longer for me. I think it's the 4th power of the diameter increases the area of the tube. So every time you can go up, they're all by 0.5 millimeters. So 6, 6.5, 7, 7.5. The largest I put in is a 9. Put 9 into a bad COPD person. It just makes life easier on the ventilator. Small tubes, pulmonologists will hate you. But if it's all you can get in, you can always change it out later. So they're always labeled by their size, and that's how people usually ask for it. So direct laryngoscopy means you're directly looking at the airway. So this is kind of the old school way. You still need to know how to do it, because if your camera goes out, something, you have to be able to know how to do it. So what do you need? Well, you need a laryngoscope. That's what's at the top. So a laryngoscope, nowadays, this is all disposable. It's kind of crazy. There are 2 main types of blades. You can see a straight blade and a curved blade. So the straight blade is the Miller. Curved blade is a Macintosh. Most people just call them Macs. So here's a Miller blade, and that's it. And like I said, you just throw this away. This is a Miller 4. The bigger the number, the bigger the blade. So you can kind of see a Miller straight until the very end, and it just kind of starts to tip. It's also very narrow. Very narrow. As opposed to, and of course, the only Mac blade I could find was an itty bitty little baby one. So this is a Mac 1. So this is for babies. And then it comes with its own handle. So you just want to, all handles will have a little bar there, and there's a little catch on the blade. You just kind of put it on and click. So that's it. So you can kind of see the difference, not only just in size. So the difference in a Miller straight blade or a Mac, that curved blade. Different situations for different blades. The Mac is going to be a little bit wider. I predominantly use the Mac blade. The only time I use a Miller is if I see somebody and I think they're going to have what we call an anterior airway. That means, and kids are this way, kids have more anterior airways, meaning their airway, when you lay them back, is higher up. Those are much more difficult. So the way you use these blades is also different. That's what we're going to get into. But that's the difference. So blade and handle. That's all there is to it. These are interchangeable, come in different sizes. There's actually a Miller 5. It's like you're intubating a horse. Yeah, it's gigantic. Y'all ever have any vet experience? Veterinarian? Yeah. So I mean, you've seen dogs intubated. I mean, it's pretty easy. I mean, you just
pull their whole tongue out.
Yeah. So and that's good to remember, because your tongue is what you're looking for. If you ever get into trouble, find the tongue. It'll lead you to the epiglottis, and the epiglottis is your friend. All right. So you need a blade, whichever. For whatever situation. You also need an endotracheal tube. So endotracheal tube and a stylet. So a stylet is just kind of this malleable, hard stick, basically. So you can see the parts of the tube there. This tube is a little different on the picture. It has this suction port. See this deal right here? That thing going up. Most tubes don't have that. basically that's an extra deal at the very end where you can do suction. So all tubes will have a line on them. There's a faint blue line. And you can see that right there, that blue line, that's has a little piece of like aluminum in it. It'll show up on x-ray. So when you see it on x-ray, that's actually what you're looking at. Look at the very end of the ET tube. You see where there's a gap in that line. So that's where you can tell where the tip of the ET tube is. There's a pilot balloon right here. That's what's going to inflate the cuff. I did not bring a syringe. So you always want to test that before you put in your tube. Make sure it inflates and holds its inflation. What else? This connector is kind of a standard connector. It's a great piece of equipment for other things, but this is what hooks on after you get them intubated. Hook it up, what you connect to. In the last, ET tube size, like I said, they're labeled on the outside, they're labeled on the tube. In adults, it's pretty standard, 7 to 8 for adults. Kids, this is the formula most people use. You take their age plus 16 divided by 4. The depth is 3 times the size of the ET tube on kids. Or, I keep it real simple, I don't like memorizing things, I just look at their pinky. You look at the kid's pinky, that's about the size of the tube they need. So, if you look at the size of the angle of their mouth, that's really the size of the blade. So I just eyeball them, okay, that looks like a tube. And so you can kind of eyeball it that way. Same thing with the size of the tube, just look at the pinky, it's a rough estimation. Years ago, we didn't put cuff tubes in kids. That's kind of changed. Now you can put cuffed tubes into kids, except for about under 1 year of age, they still went uncuffed. It was thought that cuff tubes left in would cause tracheal stenosis, kind of destroy the trachea. It doesn't really happen unless you're doing it for a long, long time, or this balloon's under a lot of pressure. There's a little device you can hook up to this. Well, the respiratory tech usually hooks it up and it tells you what the pressure of the balloon is. So, the other thing you need, besides a blade, a tube, is an end-tidal CO2 detector. So that's what that is over there. They always look like this. So basically, this one's expired. Oh, it's a PDF. I wasn't expecting it to be that small. But, so that is what it looks like. I brought the tiniest possible demonstration. So, anyway, you see that little purple, it's basically litmus paper in there that's going to change. This is, so, I don't know if it'll, let's see if it changes. So yeah, so the common thing is you're golden. So if it churns, gold, you're golden. That's all you need. So you got all your stuff, you're ready to go. So how do you use these blades? So the straight blade, the Miller. You see up there, like I said, it's more narrow, very, very tip, has a little flange to it. What you want to do, see the picture below Miller? The key is this straight blade goes underneath the epiglottis. So you're actually going underneath the epiglottis and lifting up. And then you should see the airway. Usually in anterior people, meaning their airway is more high. That's usually in kids. You can be deceived. You can have some little old lady that's skinny, scrawny, and you think it's going to be an easy airway. And I can't see jack. Okay, you're like great. And they're so anterior. So the Miller, the blade is placed under the epiglottis and lifted up. The Macintosh, or the curved blade, it's kind of the shape of the tongue. You're trying to get it in the vallecula. Right there. Right underneath the epiglottis and between the tongue. And basically trying to get in there and again, lift up, see the airway. So, here is a picture of the Mac blade sitting right basically in the blade. The Miller blade underneath the epiglottis and lifting up. Like I said, more narrow, a little bit wider. Miller, I learned several different ways. one of the first ways was the guy said, just take your Miller, 2 fingers, put it in, put it all the way to the hub, and just put it in, and lift up, and then start backing out. When you see that epiglottis flop down, pick it up, innovate. Sometimes it works, sometimes it doesn't. You also have to make sure when you go in that deep that you didn't go in the esophagus. And I have a video that'll kind of show you that happening. Okay, curved blade, straight blade, where to put them. Got it? Okay. The other thing is the direction of force. You see that red arrow? This is another just important thing. When you put the scope in, whether it's Miller, Mac, or whatever, that's the direction you're pulling. You're not cranking, you're not this way. Basically, you're lifting up and away towards the ceiling. That'll make a big difference. It sounds simple. People screw it up all the time. They destroy people's teeth. One of our employees had her gallbladder out of mercy and they broke her teeth out. Just 2 weeks ago. So you can write a check for about 50 grand. Positioning the patient. So you're getting ready to innovate. The sniffing position, everyone, basically if someone was going to do some flowers and you're going to sniff them. That's what the sniffing position is. Pushing that head forward, except if someone has a suspected C-spot injury, not really going to move that way. We talked about aligning the external auditory meatus and the sternal notch. So that second picture, that's your average patient, that's their average size, that you're going to be innovating. You can see if they're just laying flat, here's external auditory meatus, here's the sternal notch. It's going to be very difficult to see. Here's an MRI of someone just laying flat. So you can kind of see, I'm putting my laryngoscope right here. Look at this hump I got to get over to see. Very, very difficult. But if you build this ramp up and crank this person up where their external meatus is equal to their sternal notch, here's the MRI. Look how nice and straight that is. You lift up that tongue, you'll be able to see a lot easier. Like most procedures, positioning is key. Whatever the position, or whatever the procedure is, if you don't position the person correctly, the likelihood you're going to be successful is way, way low. I had a sadistic neurologist when I was a resident, and he made me do LP's blindfold. And he goes, you don't need to. He goes, you feel. So, I don't feel blindfolded now. Look. But again, that especially is a technique, central lines, whatever. If you don't position the person properly, you're just not going to be as successful. Same thing with the airway. These are simple things. Again, a lot of people get excited. They don't realize, hey, we don't have them elevated. Let's get the head up. Let's get a position. Let's take 5 seconds to remember our basics so we can get them elevated. Got it? Got it. The other thing is sometimes you'll get them ramped up like that. And you go in and try to take a look like you still can't see. The easiest thing to do, so you have your scope in, you're looking, is I reach under and grab the bottom of their head and lift their head up. And I just start moving their head. And sometimes it'll take another 4 inches, flex their neck, and I'll have someone else say, just hold their head. And you can do that. So that's why you need a lot of hands when you're doing this procedure. So, open the mouth with the scissors technique. Basically, it's just crossing your fingers, your thumb on lower, upper teeth on your index, and just kind of a scissors just to try to open them. Insert the blade. Most people say kind of insert it along the right, kind of sweep the tongue to the left. Is anyone left-handed? No, I'm sorry. It may be a little more difficult for you. Right-handed people, you're still going to hold the blade in your left hand. So if you're dominant and you go backward, they didn't make the blades for you. So it may be a little different. I haven't really encountered a lot of difficulty, but I can innovate this as well. So insert the blade, kind of sweep to the left, kind of get that tongue out of the way. Some people will have a gigantic tongue. It'll be just fighting you, and you just try to sweep it out of the way. So what you're trying to do is advance that blade down and find the epiglottis. Looking for the epiglottis, down the tongue, and those are the views you're looking for. So it goes kind of backwards. So D, you're creeping down, nothing. There's the top of the epiglottis. oh, there's the epiglottis, there's the cords, there's the money shot. So if you can't find your epiglottis, find your tongue and follow it back down. So you should always know where you are, kind of where you are in the neighborhood in the airway. Again, find the tongue. Another couple things to remember, and you'll see this a lot. I know some goofy cartoons, but keep your back straight. A lot of people, one, they'll have the person so low, they'll be like bending over and trying to see, and it doesn't work. What I do is I raise the bed up. I have the bed where the person's head is about here. Another thing is people will get so close that you start losing the ability to see with both your eyes. And so if you get too close, like their face is right here, you're going to be like going back. So really, if you have the left arm at about 90 degrees here, that's about how close you're going to be. You'll be able to see. And do not rotate your wrist. You don't want to start, again, cranking on this. You're basically lifting up and away. Okay? Remember your anatomy. Remember your anatomy. This is going to save you. Next slide's a little graphic. There's no such thing as easy money. I know somebody that needed help pay off student loans, so going to moonlight out in Podunk, North Carolina, and think you're going to just sleep until someone thinks that they're going to kill themselves that day and try to shoot off their head, and they miss. So they come in. Well, where's the airway? This is what you see. So again, what do you look for? Find the tongue. What I do, I find the tongue and I get what are called towel clips. Towel clips are these pinchy little tools, kind of like hemostats, except they're round and big, pinchy. So what I do is I take a towel clip, I find whatever is the tongue, pinch the snot out of it, and I pull it out of the mouth. You follow that tongue back, you can find the epiglottis. Very common facial trauma, and that's the only way you can find the airway. So, very important, remember your anatomy. I also was involved in innovating one of my attending's daughters, who was a fire performer. She would swallow fire, supposed to go out. She got gasoline like down her throat and just disaster. Again, there's no easy money. That happened to me, and it was awful. Okay. Again, this is just another slide on advancing the tip, where it should go. The vallecula, if you're using the MAC. Under the epiglottis, if you're using the middle. A few more pictures, and then up there, visualize the cords. That's kind of a better picture of what it looks like. We see all these pictures of down in the airway. That picture up there is really good. You can see their teeth, and that's really how big you're going to see it in real life. It's going to look about that big, and that's what you're looking for. If you can't see it, then you can perform what's called external laryngeal manipulation. Basically, you're just reaching around and trying to move their larynx around. A lot of people call it burp, back, upright, right pressure. So you push back, up, and to the right. It varies among people. Not everyone's going to be back, to the right, it's going to be left, whatever. So if you're sitting there like that person is, they're kind of looking, they're reaching around, moving the larynx around. You get it where you want it, you tell your assistant, put your hand right there. Hold the airway. Okay, give me a tube. Put it. Again, the curve of MAC blade up and away. So you can kind of see they're pulling. You can see the distance on that picture between their teeth and the blade. There's room. They're not on the teeth. Nowadays, we have all these plastic kind of. In the old days, that's an old blade, solid stainless steel, and we'd reuse them. But they would make a certain noise on the teeth. And so when you're learning, you hear like the attendant, get off the teeth! You can hear just clanking. And they're yelling at you. So that person right there, you can tell on the guy, they are rocking on the teeth. So they're trying to pull that back towards them to kind of look, and they don't realize their fulcrum is the teeth. And they're pushing down, and that's what's breaking. So pass the tube through the cords. That's what that picture is. After it's passed through the cord, you secure it at the correct depth. Look at the tube. The tube is measured. So there's numbers on the side. It'll kind of tell you. 18, 20, 22, 24. So that's how deep you are, how many centimeters you are from the tip. So a basic number to remember is 22 at the teeth. So 22 at the teeth, you just kind of base it on the height of the person. If it's someone a little shorter, maybe 21, taller, 24, but a good starting point is 22. So get it at the right depth. Do not let go of the tube. Hold on to the tube. Tips to pass the tube. The stylet, I talked about earlier. Stylets will come straight like this. So you just kind of load it into the tube. What you want to make sure of is that you don't get past the tip of the ET tube like that. It'll stick out, or some people accidentally put it through the eye like that. But what you're going to do is you're going to perforate their trachea, or you're going to perforate the back of their pharynx. So you always want to make sure that your stylet is pulled back. So the best thing to do is just take this, kind of put it through, away from the end, and just bend it over. And then that way it can't go any farther. So that way, to the tube, it's not there. Then, you can bend this any way you want. So a lot of people start out with what's called a hockey stick. You take the end, and it looks like a hockey stick. Just a little bit of a curve. Some people put these big cranks in, but what happens, depending on the anatomy, kind of how long their neck is, you go in to like intubate them, and all of a sudden, all this thing wants to do is go up top. And it's going to go above the cords. So my initial suggestion is to creep it pretty straight, except the very end, put a little kink in it, like a hockey stick. And so that way, usually, it'll kind of follow the curve and be able to pass right through the cords. If, when you're passing through, you can always rotate it, like back and forth. Like 90 degrees, back that way, that way. That'll make it easy. The other thing is have your assistant, you're going to have somebody there, usually RT, they kind of know what's going on. You're looking, you may have found the airway, you position it, you tell them hold it right there. All right, and you want to keep your eyes, as soon as you find the cords, don't look away. There should be someone there and you should just go, hand me a tube. You don't even have to look, they should put it in your hand the right way, unless they hate you, and they put it the wrong way, and you pass the tube, and you go, all right. You hold the tube, someone will remove the stylet. So the respiratory tech will come behind you, hold on, because sometimes this gets stuck and the whole thing comes out. Because, especially after you've shaped it like that, you can kind of see it's not real easy. Some people will lube the stylet to make it easier. It's not a bad idea, just because it'll make it easier to remove the stylet. So after the stylet's removed, hopefully by someone else, still don't let go of the tube. They'll hook it up to the bag them. Then you want to check where you are. So again, your end tidal, this should already be on there. Hook it up immediately. You can look at that, but you also want to listen. You listen over, the classic teaching is listen over the epigastrium first. It's going to sound funny. If the ET tube's in the esophagus, when you start bagging, it's going to have a funny sound. I won't demonstrate it because I'm not good at making noise like that. We'll do it in the cadaver lab. And sometimes the resistance is also different in the bag. You really can't count on, some people say, well, there's condensation in the tube. The tube will condensate, but that doesn't tell you if it's in the stomach or in the esophagus. Because even in the esophagus, you can get condensation. Auscultation is also a little misleading. The only way to know for sure is the end tidal, but if you just resuscitated a cardiac arrest, they're not making carbon dioxide, so you can't really rely on that. What you can rely on is your end tidal on your monitor, and your sats are staying up. So your sats are staying up, came back up, I think we're good. But just remember, your pulse ox lags behind what's happening in the body, a good 30, 45 seconds. So if it's already going down, it's already been down in the body for a while. This is just a basic video that kind of puts everything together. This one's from India. And you have a very happy patient. See? I want to be intubated. He's got an easy airway. So he's just going to gas this guy down. You can see he's put a pillow under the head. He's aligned the ear, sternal notch. You can see that pillow. He's not given any IV medication. We don't give gas. So he's just going to knock him out with gas. He does something very wrong. I'll see if y'all can tell. here in a bit.
Normal intubation usually takes only few seconds. The curved McIntosh blade should be inserted towards the right side of the patient's mouth to prevent the tongue blocking the view of
We're
the
using a
larynx.
Mac blade.
The laryngeal blade deflects the tongue
He's
to
kind of
the
entering
left.
the right side of the mouth,
The blade tip
sweeping the
is
tongue
passed
over.
along the tongue in front of the epiglottis to the valvula.
Look down
And
in
tip is
there.
used to lift the
There's
base
the
of the
abdomen.
epiglottis
Oh,
forward.
he's cranking on the teeth.
Yeah.
Oh, so
The
bad.
upward pressure on thyroid cartilage.
Now he's reaching
by an
around,
assistant
pushing that airway. See, there's a
helps
chords
visualize
right
the
there.
fall.
Of course, that guy had a
With
huge
straight
mouth,
blade,
skinny
you go
neck.
posterior to the
Should be
epiglottis
easy.
and lift epiglottis anteriorly.
So he's got the Mac right in the vallecula. He's rocking on that teeth. I
Usually
don't think I have
learners
him
make three
inside.
mistakes. They are in too much hurry. They are afraid of apoxia.
Stop
When
it.
deflects and they usually go posterior to the epiglottis and make intubation more difficult.
Pushing up, right?
To perform the process of intubation, basically two things are required. First one is endotracheal tube, and the second one is a point source of light. Now, patient. Now, gradually introduce the laryngoscope, and as soon as you are going to introduce the laryngoscope, you people can see this uvula, tonsil, and the epiglottis which is covering the trachea. You are supposed to introduce the blade just behind the epiglottis and lift it. As soon as you are going to lift the epiglottis, you people can see there is an opening for the trachea. This opening is characterized by the presence of vocal cords which are placed laterally. And in this opening, you are supposed to introduce the endotracheal tube. Unless and until this opening is not visible, you are not supposed to introduce the endotracheal tube. Of the endotracheal tube inside the trachea, the laryngoscope. The endotracheal tube is fixed at the corner.
So, that's kind of overview of direct laryngoscopy. So, as Tammy said earlier, the bougie. This is the best piece of equipment. All these fancy things, all these scopes, this has saved me more time than anything else. Basically, it is a shapeable kind of piece of plastic. What they used to do is they used to take rope and just cover it in plastic, and the tip has a 30-degree bend in it. So it's about 70 centimeters long. And you see up there, they have it in that curl. So you kind of load your tube onto it. That's called the Kiwi curl. So some Australian kind of came up with this idea that you kind of hold it like this, and that way you can kind of manipulate the bougie. So the Seldinger technique, you're going to hear that. It has this fancy name. Basically, the Seldinger technique is you put down any type of guide wire or wire and you slide a tube over it. That's it. That's how you do central lines, that's how you do ports, you do drains. That's what Seldinger technique is. So you put it over a guide wire and then put a tube over it, pick up the guide wire. So that's kind of how the bougie works. So you can put this in blind. You can just kind of put it down somebody's throat, fill the back of their tongue, put it in. What you're trying to do is put it in, and you want to catch this on the tracheal rings. So after you put this in, and you can put it in with a laryngoscope, that's the best way, because if you're using this, it may be a difficult airway. So you're looking, you can't see anything, you put this in, and then what you do is when you pull this back, it'll catch on those rings, and you can feel it. You can sometimes hear it. You can actually, and then you know exactly where you are. Push it in a little bit more, put the tube over it, take it out. Sometimes this is put in blind without seeing the vocal cords. You just slide it under the epiglottis. So in bad airways, you can't see anything.
Did you use that with your trauma patients and have their face?
No, just
You just did it with your finger, hold their tongue?
just grab it, have someone hold that, suction, suction, suction. They will see it. So And those people, again, have to sit up. You have to sit them up. As soon as you lay them back, they're going to drown, and all the stuff's going to fall back their throat. So sit-up position is key. So, I've got to go fast forward. This is the most bizarre video. It's like it was made in some crazy person's basement. You'll see what I mean. And there's crazy music. Okay, see how it looks like someone's basement? So here's a big guy. You've got him ramped up. You've got his ear and sternal notch. Everything's looking good. One-hand technique. Got their fingers under the jaw, trying to bag them up. This guy's got a lot of pus in his airway. Do you see the bougie going under the epiglottis? Right through the cords, up the airway. Music gets more exciting. Now sometimes when you put the ET tube over the bougie, it doesn't necessarily just going to go straight in. You're going to notice he's going to kind of twist back and forth. It's kind of a twisting motion. So, got the balloon all the way through. Move the bougie. Still hold the balloon. Go. Put them on the circuit. You see how long it takes to put that on the circuit? There's this inside of the 40. See those big little rises? We're in. We got CO2 coming back. Good. So this is another. This is another beautiful airway. That's all you can see. There's the epiglottis. Can you see cords? Can you see anything? No. You're snaking that bougie to tip up underneath the epiglottis. That's all pus coming from everywhere. Different guys. Big swollen epiglottis. Suction, suction. Trying to figure out where the bougie is. Still looking. Go back in. Like, all right, screw it. I'm just going to put this in lightly. Let's just sink this in. I'm going to push it in a little bit further. I'm going to pull back and see if I can feel that click on the readings. I think I do. I do. Advance it just a couple centimeters. Put it too. There you go. You always need good stuff.
Do you sing the James Bond theme song in your head?
I do. Exactly what I do. Confirm placement. We talked about internal CO2. You want to make sure they're maintaining or increasing their SATs. You cannot rely on misting of the tube or auscultation. The first thing I listen over the stomach, listen over the left and the right, making sure they're equal, and then obtain a chest X-ray. You can see here the end of the ET tube, that little stripe on the tube. Right there. So you can kind of see, and then some distraction. You can probably see the carina.
Yeah.
This mouth show up. Basically, you can kind of see the left main, right main, so if I can put here, so it ends right there. The other thing is, I look at is make sure it's below the level of the clavicles. So you can see the head of the clavicles here and here. Just get it below the level of the clavicles. Post-invasion, secure it. Put their head up. Make sure they're sedated. Some pain medicine, suck them out because they're going to have junk everywhere. Place a gastric tube and check the pressure of the balloon of the ET tube. All right. Video laryngoscopy, this has changed everything. So video laryngoscopy is what everybody does now. There's different products. You can kind of see that black one there is what's called a glide scope. The middle one is a keen vision. and then the other one's an older light scope. Basically, these are specially designed blades connected to a camera. This is really what people reach for first now. Instead of direct laryngoscopy, you go straight to video. So this is a quick video of a laryngoscopy. Good music and hurry along. Just given medication. Again, this is an elective ORK. Nice on. This is a great video. This is probably one of my favorite videos because it shows you how you can screw it. Very easy.
With the video?
With the video scope. It's only like 45 seconds long. So this is actually going to show you what the esophagus looks like. Most people don't show you this.
During a routine laryngoscopy and intubation using a GlideScope AVL video laryngoscope, the first structures visualized, which to the inexperienced might appear to be the larynx,
There we are.
is in reality
not.
the esophageal inlet. This is learned after withdrawal of the video
Oh, there's
laryngoscope,
it was.
and the true laryngeal structures are seen.
Top, you'll see the airway, bottom, esophagus. See? That right there.
Practice of initial epiglottic
That's how easy it
muscle,
is to screw up.
as taught by Dr. Richard Levitan, would have prevented this error.
So what they did wrong was they went in really deep right away. They basically pushed that laryngoscope all the way in, lifted up. That looks good. You start bagging and also nothing. Sats go down, crap. So it's very easy. That esophagus a lot of times can look a lot like the cords. Because even though we've seen pictures of cords that are really bright white, sometimes they're the same color as everything else. This is just another video. And here is an altered anatomy. This guy had surgery on his larynx for laryngeal cancer. This is happening more and more common. People are living longer, having more things done to their airway. So you'll see funky anatomy nowadays. Most of the people use
A man who is treated with radiation and chemotherapy for laryngeal cancer presents for direct
You're like, what is
laryngoscopy
that?
and esophagoscopy due to a recurrence of his cancer. After the induction of anesthesia with muscle relaxation, the anesthesiologist is unable to visualize the larynx with
Yeah,
the video
all you can see is a big
laryngoscope,
fat abnormal
but is
epiglottis.
able to follow the bubbles produced by
See the bubbles?
cardiobolismus in order to complete the delivery of the tracheal tube. Endotracheal intubation, cardiobolismus, able to follow the bubbles with video laryngoscope,
Watch right in the middle. See the bubbles?
but is able to follow the bubbles produced by
What I've done too is
cardiobolismus
just press on the chest.
in order to
Crank on someone's
complete
chest.
the
You look
tracheal
for the
tube.
bubbles to come out.
Endotracheal intubation is verified.
So, if you do intubate the esophagus, tubes in the esophagus, sometimes leave it. Just leave it there and go back and re-intubate if you know where not to go. So I've done that. Come in, someone's intubated, like, okay, it's in the esophagus, just leave it. The mouth gets a little crowded, but you know exactly where not to go. Now you have a landmark, you're like, okay, I just need to go about it. All right, we are in the home stretch. RSI. So RSI, you'll hear about rapid sequence intubation. This is a process that's done in emergency settings, critically ill people. It's stepwise of giving medication. Y'all want to take a break or just? Okay. Stepwise of giving medications that you induce them and paralyze them to maximize your success. This is routinely done everywhere. It gets a little tailored to every situation. It's now changed to delayed sequence intubation in a lot of people to try to not rush through it, because you'll see that this can have some problems. So there's the 7 Ds of rapid sequence intubation. There's prepare, pre-oxygenate, pre-intubation optimization. You then induce and paralyze them, protect, placement, and post-intubation management. Quickly go through each one. Prepare. We've talked about this. Get all your stuff together. Assess the airway for a problem airway. The common mnemonic taught is lemon. You look externally. Do they have a funky looking anatomy? There's the 3-3-2 rule, the Malampati score. Do they have an obstruction? Do they have a big neck? They're obese, or their neck doesn't move. The 3-3-2 is evaluate for the difficult airway. Can you put 3 fingers in their mouth, up and down? I'll be real honest, I hardly ever do this. I just have them open their mouth. Open your mouth, okay, that looks good. You can measure the distance here from the middle part of the mandible back to the hyoid, and then this other 2. Most people have gigantic necks. You can't feel, you just have to anticipate that every airway is going to be difficult. The Malampati, again, this is classical teaching. You're going to see it everywhere. Open their mouth. What can you see? So class 1, hey, I can see everything. I can see the tongue, I can see the back of the throat, I can see the uvula. Class 2, well, the tongue's kind of over the uvula. 3, I can barely see the soft palate. 4, I can't see anything. Little mnemonic there. Assemble people, equipment, medications. Suction. Make sure suction is hooked up. It's one of the most important things. When I'm at the head of the bed, suction, I put it under the pillow. Suction's ready, it's working. All your blades, video, get oxygen source, position the patient, monitors, get them on the monitor, make sure they have 2 IVs if possible, and get all your drugs together. So, what you want to do is you don't want to keep trying to innovate. You want to maximize the first time you're going to try, you're going to get it done, because the rate of adverse events goes greatly up. The longer you take, the more times you have to take. You can see 14% versus 47% rate of adverse events, getting on first versus second and third attempt. So you're going to stay calm, because this can get very hairy, very quick. You're in charge. Everyone's going to look to you. You're the captain of the ship. You've got to tell everyone what to do. This is not a time to, most of these people are your friends that you work with. Sometimes you have to yell. Sometimes you have to yell at friends. They may get mad at you later, but everyone understands. The thing is, you're in charge. You have to stay calm. Take a deep breath, because you're going to get some big people that are nightmares. You're going to get people that have no mobility. That guy's like that. One of the worst airways I had, I was called to the unit. They extubated this guy. Pulmonologists sometimes extubate people based on blood gases without looking at the patient, which is a totally wrong thing to do. You don't base treatment on blood gas. You look at the clinical situation. Anyway, the guy's extubated. He looked like this guy. When I took the pillow out, that's what he did. I could not move his head. I was just like, when I moved his head, his shoulders went up. And I was like, what? What's going on with this guy? And they're like, he had a craniocervical fixation. I'm like, what? So they drilled holes in the back of his cranium, put rods going all the way down his cervical spine. He was fixed. You could not move his neck. And he was fixed, flexed. The worst possible situation. This guy's already, they've called this code, he's already kind of in extremis. And I was like, we never got him in there. I cracked him. He died. You should have. Let's get on. Abnormal anatomy, this guy, he walks in and people will be scarred, they'll have keloids, scarred down, they'll decrease their mobility. But you got to stay calm whatever you face. So this is what the situation usually looks like. There's people everywhere, stuff flying everywhere. Try to keep it calm. This is a much more nice looking environment. Everyone's got their nice stuff set up to the side. Everything looks more peaceful. So if you don't stay calm, the rest of the people aren't going to stay calm. So everyone's going to feed off kind of how you act. All right, pre-oxygenation. One of the most important things you do is give the person oxygen. You just don't put a mask on them. Nowadays, that bottom picture, that guy hooked up to that thing, that's high flow nasal oxygen. So it's these machines shove oxygen up your nose at an incredible rate. The nose is the best way to give oxygen. Better than a mask, the nose is the best way. Everybody, if you don't have high flow, put them on a nasal cannula, no matter what. You also, you can see that guy, the first picture of that guy, he doesn't have a nasal cannula, he just has a face mask. Then he has both. You want both on. You want to give as much oxygen as fast as possible. The chart, this is just how long you have to desaturate. So if you can pre-oxygenate somebody, hopefully a healthy, normal-sized person, you can get almost 8 minutes of apnea and intubate. It really is incredible. But you have to spend probably a good 3 minutes pre-oxygenating the person. So you want to give them as much oxygen as possible. Both those guys are sitting up, getting oxygen. So pre-intubation optimization. So you want to look at their vitals. You want to address any areas of physiologic vulnerability that could complicate resuscitative efforts. So first things first. If they don't need an airway right now, they're oxygenating, but they're going to need one, give them oxygen, but their pressure's low. The most common thing you're going to run into is hypotension, either from their disease process, they're bleeding, they're dehydrated, they're septic. So you're going to have to do something about their pressure. Give fluid, give blood, put them on a pressure. Try to do that because when you give meds to induce them, they're going to drop their pressure. Depending on what they need is kind of how you treat that pressure. The other thing that's going to happen is once you intubate them, you start putting them on a vent, you start bagging, their intrathoracic pressure is going to go up. So all of a sudden pressure, and that will decrease venous return. So much pressure, decreasing venous return, that'll cause their pressure to drop even more. So you can see on that monitor, their blood pressure is 51/33, heart rate's 160, their stat's 97, respiratory rate's 20. So fix the pressure if you can before you intubate. So the big thing with RSI is paralyzing and inducing. Inducing means we're inducing a state of disassociation. We're knocking out. So it's good for you because you won't remember this horrible event. So you give these drugs at the same time. You'd like to give the induction agent, then a paralytic. That table, etomidate, ketamine are probably the two most common drugs given. Ketamine is now probably the drug of choice for intubating. It's a great drug. It used to come with a bad rap that it would increase intracranial pressure, all this other stuff. It's not really true. Most people are giving it now as their top drug. It also has a bronchodilatory effect, so in asthma, helps dilate the airway. And then the two main paralytics used, succinylcholine and rocuronium. I grew up using Sux almost 99% of the time. It's fast. Usually it's less than a minute after giving both drugs, the right person's ready to intubate. It also goes away fast. So if you run into difficulty, they had some type of drive, and you can oxygenate, hey, they're back. Rocuronium, you give it, it's going to last about 30 to 45 minutes. So if you can't bag them, if you can't oxygenate them, now you're really stuck. So that's the danger of RSI. If you commit to paralyzing them, and you can't intubate them, you may have just got yourself into a big, bad corner. So that's why a lot of people are doing delayed sequence intubation, where they may not give as much drug. They may give a lower dose. But the classic teaching is giving both drugs, maximum dose, same time. So, positioning protection we've kind of talked about. If they have a C-spine issue, inline mobilization. Again, Selleck maneuver, external crack-weight pressure is not recommended. Placement with proof, place the tube. You can check if they're relaxed by their jaw. Usually their jaw will just fall open. You can kind of move it up and down. You can kind of tell, okay, they're relaxed. With succinylcholine, they'll defasciculate. They'll sit there, kind of shake for a second. Confirmed tube placement, we talked about. Post-intubation management, secure the tube. You can see down that picture, different ways to secure the tube. RT usually has a little device they put on there. Don't let go of the tube until they're secured. Because people will roll people, they'll be doing something, they'll pop out. Hook them up to the vent, get them on sedation, keep them comfortable. This we don't need to watch, it's a very long video. It's just a basic intubation RSI. All right, and no airway talk is complete without a bunch of algorithms, what they usually always do. These are more that you can kind of look at, to kind of get in your mind. This is basically how you run through intubating somebody and what to do in certain situations. So, you know, it's not real tough. If they're unconscious, they're near death, yes, go to crash airway, put in a tube. You know, if that fails, go to failed airway. That means you're gonna do whatever you can, if nothing works, you're gonna cry it. So if they're unconscious, not a difficult airway, well, if they're unconscious, you're still gonna innovate. Now, RSI, if someone's unconscious and they don't have a lot of tone, I usually don't RSI because it's not worth the risk. Why? If I can oxygenate them, ventilate them, they're unconscious, I'll just try to innovate. Unless they have a gag reflex or for some reason they're still fighting. There's several algorithms. This is the main emergency airway algorithm. You know, again, this all comes down to, do you think it's going to be difficult, and prepare for the difficulty. Be ready with every modality you have for every airway. That's why you have airway carts. Usually you have an airway cart that has every possible equipment piece on it. So you have everything at your disposal. So, crash airway, failed airway, difficult airway, and cry. So at the end of all these algorithms, you can't do anything, you have to crack somebody. Probably the biggest thing about criking is don't wait too long. Don't wait till they're resting. So if you've gotten, and you're just like, this is not going to happen, we need to crike, make the decision, commit to it, and do it. The hardest thing about criking somebody is the anatomy, and finding where to cut. So you see in that picture, you find the thyroid cartilage and the cricoid cartilage. In guys, probably easier, Adam's apple. Right here, thyroid cartilage. What I typically do if I'm laying beside somebody, say their head's up here, I grab the larynx here, I just grab it, and my finger usually will point right down to the cricoid membrane. So you kind of walk down from the notch, kind of feel the cricoid. I mean, you're looking for an area that's about that big. And sometimes these people are blown up, they're fat, big neck, whatever. It's very difficult. So you make a midline incision, make it big. You know, don't worry about cosmetics. Don't make it 2 centimeters. Make a big incision. You open it up. This is the traditional technique. You control that larynx the whole time. Midline incision, continue to hold the larynx. Cut down. You can find the membrane. Make a horizontal incision in the membrane. There's a device called a tracheal hook. It's in that picture. It's a very long, kind of skinny, with a big hook at the end. Put that down there, pull it back. You can dilate, or you can just put in what's called a Shiley. Basically, this is what it is. It's a tiny, basically, tube. So it'll have, comes with cannula. This is a dilator. So it has that end. So basically, that's how big that hole that in the membrane needs to be. So as soon as you find it, put it down in there. You take this out. Put the cannula in. Cannula's on there, and then you're able to go directly and start bagging. The main complication I see is people will be beside the trachea. And so you put that in, you think you're in, here's the trachea, you're beside it, you start bagging them, their neck blows up. Then you're like, oh, great. Now the anatomy's even worse. They're just blown up. And like I said, if you do all the basics, simple maneuvers, just chin thrust, positioning, you don't want to get to this situation. Once you get to this situation, the likelihood of being successful is low, and for a good outcome, moving forward. Quick video.
Hey everybody, it's Joe. Today, no matter which technique you prefer, make sure there are no defects in your cuff.
Checking the balloon.
The first step in this procedure is we're going to take our non-dominant hand, take your index finger, and you're going to walk down from the thyroid cartilage and find the cricothyroid membrane.
It's not going to be far.
If the situation permits, make sure you cleanse the site.
It seems like
After securing our scalpel, we're going to make a vertical incision from mid-thyroid cartilage to the cricothyroid
he's
cartilage.
left-handed.
After making your vertical incision, repalpate the cricothyroid membrane. Next, take your scalpel, place it horizontally, and puncture through the cricothyroid membrane. Take your tracheal hook, insert, and elevate against the tracheal ring.
Some people pull down. Some
After
people pull
securing the site with your trach hook, we're going to take the tip of the cric key and insert it into the
This is a special
incision.
product called a cric key.
Once placement has been confirmed, remove the trach hook by turning it towards the patient's shoulder. Next, we're going to inflate the cuff and remove the bougie. After removing the bougie, take your EDD and confirm placement. We're going to secure the device in place.
Just that easy. Here he is. So this is on it. Okay. So again, you're looking for a very tiny section. That's what both fingers along the thyroid cartilage. Your finger should kind of be almost right there over the membrane, just in that neighborhood. You make a midline, vertical incision. It'll bleed. I'd probably even do it bigger than that. We're going to extend it. Now they've created a horizontal incision in the membrane. Here comes the tracheal hook. Put it in. We'll get a lot more blood. They kind of have what's called a trousseau dilator. And basically you just kind of place the